I often tell people with Parkinson's disease that if they do not have constipation and they do not have trouble sleeping, then they shouldn't change a thing, because these are the two most common symptoms, what we call non-motor symptoms, that people with Parkinson's disease experience. So today we have brought in an expert on sleep to hopefully help the plethora of individuals out there with Parkinson's disease that do have problems with sleep. So Dr. Alicia Roth is a clinical health psychologist and associate staff at the Cleveland Clinic, where she specializes in behavioral sleep medicine. She completed her doctoral training at the University of Florida, did an internship at the Baltimore VA, and studied behavioral sleep medicine fellowship at the Cleveland Clinic. Her work focuses on treating a range of sleep disorders, including insomnia, circadian rhythm disorders, as well as nightmares, and then adjustment to CPAP for people who have sleep apnea. She has published numerous research articles on the intersection of sleep and chronic health conditions, such as fibromyalgia, heart disease, and then for people with Alzheimer's, as well as their care partners. So welcome, Dr. Roth.
Hello, my name is Dr. Alicia Roth. I'm a clinical health psychologist in behavioral sleep medicine here at the Cleveland Clinic. And today I've been asked to talk about healthy sleep and sleep disorders in Parkinson's disease. I first wanted to let everyone know that we have a full behavioral sleep medicine team here at the Cleveland Clinic. So it consists of myself, our director of behavioral sleep medicine, Dr. Michelle Drerup, Dr. Alexa Kane, who is at the Mellon Center, and Dr. Lucy Carrier, who is also a clinical health psychologist. She's at the Lou Ruvo Center for Brain Health in Las Vegas, but she also does behavioral sleep medicine and neurological disorders and movement disorders. So we have a whole team here to support you and your sleep health. I wanted to start out today by talking about why do we sleep? And I think most people understand that sleep helps our brain functioning and sleep helps our body functioning. So sleep affects mood. So sleep can lead to low mood, irritability, frustration, anxiety. It can lead to problems with thinking ability, or what we call executive function. And it can impair our flexibility in creativity and thinking, and can impair our judgment as well. It can impair our attention and concentration as well. Our sleep also helps our body function. So although sleep is mainly in the brain and helping the brain, there's a lot of restorative functions that the brain has for our body, including our immune system. So this is important for fighting infections, minimizing the impact of stress and a variety of diseases, and our hormone system. So sleep is important for the regulation of our body's hormones. So sleep changes with age. There are natural age-related changes that we have with sleep. So with age, sleep tends to get shorter, lighter, which means we tend to get less deep sleep. It takes more time to fall asleep. Sleep becomes earlier, so we tend to want to wake up earlier and go to sleep earlier in the day when we're older. It's more restless, and we tend to have more nighttime awakenings. So one question that I always get is, how much sleep should I get? Well, for adults over 65, the aim is 7 to 8 hours. And this graph shows us that sleep duration and the amount of sleep that we need evolves over our lifetime. So if you look here, every column here is a different stage of life, starting with newborns and going to older adults. The blue line here represents how much sleep is recommended, and then kind of plus or minus above and below it. So newborns, it's up to between 14 and 17 hours of sleep. And then as we get older, our sleep need decreases. And then when you get into the older adult range, it's about 7 to 8 hours. Well, one thing I always reference is that sleep quantity is only part of the picture. We also need to consider your sleep quality. So just getting 8 hours of sleep is not enough if that 8 hours of sleep is broken up. 8 hours of solid sleep is not the same as 8 hours of broken up sleep. So you might actually do really well on like 6 hours of solid sleep. And it doesn't sound like a lot, but because it's solid sleep, the quality is higher. So when we're talking about your sleep needs and what's going on with your sleep, we need to consider quality along with quantity. So sleep is a particular problem in Parkinson's disease. And this is because Parkinson's disease has very special features that can affect our sleep system. First and foremost, the disease pathology. So there's research to show that part of Parkinson's disease is deterioration of sleep controlling regions of the brain and deterioration of dopaminergic centers in the brain that affect our sleep, especially our REM sleep, which we'll talk about in a moment. The disease symptoms, what actually manifests because of Parkinson's in your outward behavior, also makes a difference on your sleep. The motor symptoms like tremor, rigidity, dystonia can make it difficult to sleep and be comfortable in a sleeping position. Nocturia, waking up a lot to use the bathroom, can interrupt your sleep. And then, of course, depression, anxiety, or Parkinson's related hallucinations can interrupt your sleep. We also know that there are medication effects, medications that you might be taking specifically for Parkinson's that can affect your sleep. So really anything that you're taking for Parkinson's can be disrupting to your sleep, although some may help. So an SSRI, something you might be using for depression or anxiety, we know those medications can help with sleep. And a part of the pie that I didn't include, but I think is important, is how stressful Parkinson's might be. I think we can all agree that stress and changes in your life are going to affect sleep. And so having Parkinson's disease and managing those symptoms, managing your appointments, managing your relationships with other people, continuing to lead a high quality of life can sometimes be very stressful. And any big changes in life or big stressors in life can lead to sleep problems. This was a surprising number for me, but 66 to 80% of those with Parkinson's report that they have poor sleep quality. And that's from a 2018 report from the Parkinson's Foundation. So sleep is obviously a very big problem in persons who have PD. I want to talk about now what kinds of sleep disorders that we see in Parkinson's disease. Now, the most common sleep problem in PD we see are frequent nighttime awakenings and waking up too early in the morning. The other thing that we see a lot, which I did not put on this slide, is sleep-related hallucinations. So hallucinations either when you're falling asleep or when you're waking up. And those hallucinations can be visual, they can be auditory, they can be sensory, like sensing something is in the room. I want to go through 3 specific sleep disorders and the problems that may manifest with these disorders. So the first is what we call insomnia disorder. So insomnia disorder is very straightforward: problems falling asleep, problems staying asleep, waking up too early in the morning. or some combination of all three. Now, insomnia disorder manifests as daytime fatigue or sleepiness during the day. It can also contribute to poor mood, like anxious mood or depressed mood. People with insomnia will also say they have difficulty with attention and memory. One way that a lot of my patients with insomnia describe their day is that they feel tired but wired. So they feel kind of in their bones that they're sleep deprived. However, they couldn't go to sleep if they really wanted to go to sleep. So they feel very wired during the day. And that's a very uncomfortable kind of stuck feeling, is like feeling sleep deprived, but having your brain be too alert to go to sleep. Now, the treatment that we have for insomnia disorder is called cognitive behavioral therapy for insomnia, or CBTI, which I'm going to go over a little bit more in detail towards the end of our talk here. There are other options for treating insomnia disorder, including medications for sleep. What we know about medications for insomnia disorder is, even amongst relatively healthy people who do not have another chronic medical condition, sleep medications can be a little hit or miss. Sometimes they work really well. Sometimes they don't work. Sometimes they work at first, and then over time, they lose their effectiveness. We do know as we get older, our body digests and metabolizes that medication differently. So it can have those medications can start having serious side effects like dizziness, problems with your gait, problems with having a greater fall risk. And so medications for sleep may not be a great idea if you are having, severe movement-related symptoms with your PD. The second disorder that's very common in PD is what we call sleep-related breathing disorders. So the two most common are what we call obstructive sleep apnea and central sleep apnea. The prevalence rate for this is really high in PD. It's about 20 to 60% of people with Parkinson's. This is breathing disorders like sleep apnea are actually very common in the general population too. So I think in the general population now, it's anywhere from 10 to 15% of people have sleep apnea or some sort of breathing disorder related to sleep. But of course, that prevalence rate is much higher in PD. So with sleep apnea, we see recurring periods of interrupted breathing while sleeping. So you're holding your breath or you're not breathing optimally. And sometimes this is associated with a drop in your blood oxygen levels. And then this will result in your brain having to wake itself up or come to some level of alertness in order to breathe. And so you might be seeing snoring or gasping for air, but sometimes not. People who have apnea will feel very fatigued, very sleepy during the day. Unlike people with insomnia, people with sleep breathing disorders will be able to sleep during the day. A lot of people report a morning headache, difficulty with attention and memory. So the gold standard for sleep-related breathing disorders is CPAP or BiPAP machines. There are also, if CPAP or BiPAP is not tolerable for you, there are other options like dental devices, mouth guards that can be created for you to help keep your airway open, or airway surgeries to open up your airway. Now, a particularly poignant and sleep disorder that is really regulated to Parkinson's is a disorder we call REM, sleep behavior disorder, or RBD. During REM sleep, so we have different types of sleep. We have light sleep, we have deep sleep. and we have REM sleep. And most of our night is light sleep. About 50% of our night is going to consist of light sleep. 20 to 25% of your night is deep sleep. And deep sleep is where all of that body restoration happens. And REM sleep, or rapid eye movement sleep, is the other 20 to 25% of your sleep. And REM sleep is where brain restoration happens. And your brain is very active during REM sleep to do all the repair work it needs to do for your brain. So during REM sleep, our body has learned to paralyze itself during REM sleep because we don't want to act out what we're experiencing in our brain during REM sleep, because they can be very vivid, very strange, or even nightmare activity. In RBD, people start to act out their dreams or their nightmares, and they remember having very vivid dreams or nightmares. And this is because the body is no longer paralyzing itself properly during REM sleep. Now, this is a disorder that is particular to PD because we believe that some of the areas in the brain responsible for Parkinson's disorder and loss of dopamine also affect the body's ability to paralyze itself during REM. This is sometimes the first symptom of PD in a middle-aged adult. The risk for this is injury to yourself or your partner, dangerous behaviors outside of the bed, like leaving the house or getting in the car, or acting out your dreams. And most people will report that they really have unrefreshing sleep. First and foremost, we have to take safety precautions if someone has REM behavior disorder to make sure that if they do act out their dreams, they're not going to harm themselves. There are some very effective medications for this disorder. From my end in behavioral sleep medicine, what I try to do is improve overall sleep, because typically people with RBD don't have good sleep habits or behaviors and don't have really good sleep overall. It's not just this acting out behavior. So a lot of y'all sent in questions prior to my talk, and I really appreciate seeing those. And a lot of the questions were geared towards how do we treat sleep problems with behavioral changes? Like, what can we do for sleep? So that's what I want to go over. We know from a scientific perspective, habit and behavior changes are usually more effective than medication when it comes to insomnia and problems with, falling asleep, staying asleep. So in order to understand why these changes are effective, I'm going to teach you about two things that control sleep. The first is what we call our circadian rhythm. So this is our internal clock, and it mostly follows the light and dark cycle. We're asleep when it's dark outside, awake when it's light. There's some variation in this for everyone, right? So you might be a morning person or an evening person. Part of sleeping better is knowing your rhythm and having a sleep schedule that matches. So you don't want to be doing things that are against your natural internal clock. The second thing that's really important to understand about what controls your sleep is something we call sleep drive. So wake and sleep are like two sides of a seesaw, and they kind of move back and forth during the day. And when you're maximally awake, you're minimally asleep. And the opposite is true. When you're maximally asleep, you're minimally awake. So we want your sleep drive to be as high as it can possibly be when you get in bed. And if your sleep drive is as high as it can possibly be when you get into bed, that increases the chance that you're going to fall asleep quickly and stay asleep quickly. So the tips that I'm about to give you are mostly centered on keeping that high sleep drive. My first recommendation is for your sleep is if it ain't broke, don't fix it. If you're sleeping really well, don't start to make big changes to your sleep just because you've heard this is better for your sleep. But what does a good night of sleep look like for you? This is relative to everyone, to every individual. There's not a one size fits all when it comes to what you should do for your sleep. But I always tell people if you're already sleeping well and you've got a routine that works for you, don't fix it if it ain't broke. But here are some basics. So first and foremost, don't ever get into bed until you're very sleepy. So that goes back to this idea of a seesaw of sleep and wake. You want to make sure that that sleep drive is as high as it can possibly go before you get into bed. The second is keeping a consistent wake time. So that has to do with the idea of your circadian rhythm. You want to set your clock, your internal clock. And the more consistent you are with that internal, with your wake time, the more consistency your internal clock has. And so keeping a consistent wake time is actually really, really valuable. You may have heard get into bed at the same time every night. Actually, when you're not sleeping well, keeping a consistent wake time can be more valuable. You may have heard this before, but don't stay in bed if you are awake. You should get out of bed, do something pleasant or interesting until you're sleepy again. So inevitably people say, this doesn't put me back to sleep. It's not supposed to put you back to sleep. It's supposed to train your body just not to be awake in bed. We never want you to be in bed awake because that associates bed with wake. We want bed to equal sleep. However, you should be mindful of any safety issues of getting in and out of bed or walking up and down the stairs. So if you feel like getting in and out of bed would be difficult for you, or you're having problems with gait or tremor, you should devise a plan to either sit up in bed if you can, and not just toss and turn. Maybe sit up in bed and read a book or listen to an audiobook or a podcast. Ideally, you would want to avoid naps, but for some people with chronic illness, including PD, naps are really important to quality of life and feeling good throughout the day. So I tell people to take a smart nap. Take a nap at the same time every day, ideally before 2 or 3 p.m. Keep your nap less than 30 minutes so that you don't get into deep sleep. And do it in your bed. And if you have a CPAP or a BiPAP, take naps with your CPAP or your BiPAP. And finally, use your CPAP or your BiPAP. If you do have sleep apnea and you're not treating that sleep apnea, no matter how much sleep you get, you're not going to feel refreshed. You are having trouble with your sleep and these strategies aren't effective, please consider seeing a sleep medicine specialist. There's 2 types of medicine specialists here at the Cleveland Clinic. We have sleep physicians or nurse practitioners who help diagnose and treat sleep apnea and REM behavior disorder. They can prescribe medication and prescribe. There's psychologists like me, sleep psychologists, who provide CBTI. We help people adapt to using the CPAP, and we do behavioral treatment for REM behavior disorder, like helping you get good sleep, still have good sleep habits. So you've heard me talk about this thing, cognitive behavioral therapy for insomnia, or CBTI. This is the gold standard for insomnia treatment. It's a brief 4 to 8 session therapy with a sleep psychologist. We meet every 2 to 4 weeks. And it's an intensive program to help improve insomnia. So as part of this CBTI, you would have an evaluation with a psychologist. get intensive sleep education, sleep and PD education, complete weekly sleep logs that are analyzed by us. We would teach you specific your sleep drive. Another thing that I help people do is redefine their relationship with sleep. Because if you have insomnia, I would say you don't have a good relationship with your sleep. We would teach relaxation exercises. So this is the gold standard for insomnia, and we do offer this here at the Cleveland Clinic. So in conclusion, good quality and adequate quantity of sleep is very important with living with PD. So we don't want to just think about how many hours you're getting, but the quality of your sleep. Sleep disorders are very common in PD, but they're also very treatable. For everything I talked about today, there are solutions to them. The key is working with your doctors, whether they be sleep physicians, sleep psychologists, or your neurologist, to create personalized plans for you. It's not a one-size-fits-all situation. So please talk to your doctors, your medical providers, the caregivers in your life about your sleep and your concerns about your sleep, because your sleep is very important to your quality of life and managing this disorder. Thank you very much.